All right, everyone. Let's get started. So, good evening and good afternoon. My name is Graham Reed. I'm chair of the Canadian Spondylitis Association. Very honored to be joining you as a guest on Musqueam, Squamish, and Tsleil-Waututh lands, what's currently known as Vancouver, and even more excited to present to you this webinar on psoriatic arthritis with an expert in the field and a friend and important supporter of the CSA, Dr. Chandran. We all know that you're here for him. Maybe we'll say, we'll just wait a minute, but I think we'll acknowledge that as we kind of get settled, many of us are experiencing a different from normal situation, and many of us are dealing with uncharted circumstances. So want to send our best wishes for you and your family on how you navigate that. Also how we kind of bridge this divide, this kind of conventional divide of personal and professional, and want to appreciate all of you joining. Also just want to point you to some of the resources that we've developed on kind of the intersection between spondyloarthritis and COVID-19. And many of those can be found on our website, where this will also go after we're done sharing. Now, I'll go through my slides quickly, and then turn it over to Dr. Chandran. And first, want to wish all of you a happy National Psoriatic Arthritis Awareness Day. It was a perfect day for us to hold this specific webinar on psoriatic arthritis, noting the wide diversity of different people living with spondyloarthritis, and Dr. Chandran will get into those differences as soon as I finish up. We always appreciate our ongoing support from our different pharmaceutical partners. Very grateful for their support in putting stuff like this on. As I mentioned, we'll provide a brief overview of the CSA, provide a quick, or Dr. Chandran will provide a comprehensive presentation, and then we'll have a section for questions and answers. You'll note on your kind of Zoom bar that there's a section that says Q&A, and in that you'll be able to ask questions, and myself and Wendy will help moderate. Wendy, being the executive director of the CSA, will help moderate those after the presentation happens. Also noting that many of you were able to share where you're from. If there are other technical problems, please, we have our staff, Dan, supporting, and we'll try to work out as best as we can. So I wanted to talk about who the CSA was. If you've tuned in before on some of these webinars, you likely have heard this spiel, so I'll go relatively quickly. A lot of the content that we're generating and that we produce can be found on our website, and so I won't get into too much detail. We are the only national association with the sole purpose to support those living with spondyloarthritic diseases. We have a few different sister or brother organizations in the UK and in the US, mostly focused on ankylosing spondylitis, a condition that I live with, as well as I live with Crohn's as well. We are not-for-profit. We are pursuing our charitable status. We have a board comprised of the majority living with different spondyloarthritis or affected by spondyloarthritis. I mentioned that we have our executive director, Wendy, and we also have international partners. Now, about a year ago, we embarked on a new kind of strategic vision for the organization, and concluded with this mission statement, being the leading voice for the spondyloarthritis community in Canada, providing four things: support, education, awareness, and advocacy. And those four things kind of lay the, foundation for the work that we're doing and the content that we provide to those living with spinal arthritis. Those four strategic pillars being education and information, advocacy, awareness, and support. In kind of spirit of time, I'd invite you to check out more about that on our website. We have posted our strategic plan, and it kind of, I guess, projects the vision and the direction for the organization in the next several years. And we look to continuously iterate on those objectives and that forward-looking vision, and hope that, you know, this webinar itself is the opportunity for you to be more and more involved with the work that we're doing, including as we continue to build our supports for those living with psoriatic arthritis, which is why we're very excited to have this webinar specifically focused on that. And we'll look to continue to provide resources for those living with psoriatic arthritis. I won't spend too much time on the different things that we do. Obviously, some of you may know those as you signed up and registered for this webinar. We're heavily focused on building awareness for what it means to live with spinal arthritis and its various implications, whether physically or mentally or emotionally. We have done a chronic disease distress webinar several months ago, which we're going to build on with more resources for mental health as we all navigate these chronic illnesses. And, you know, we do a bunch of different things that have changed with the current situation being the pandemic, but we've been able to shift quite quickly to offer these sorts of webinars that provide information directly to you, and want to acknowledge the work that our ED Wendy has done to do that and to cultivate these series of resources that help support those living with spinal arthritis. We also work in advocacy and research. We, for the first time last February, supported a prize at the Canadian Rheumatology Association's meeting. This is the first time that we've formally supported research, and we're looking to continue that trajectory, recognizing that, you know, there's a specific focus for us around supporting patients' engagement and patients' involvement within research. Dr. Chandran is part, and we have many partners in the spinal arthritis kind of research environment within Canada, and we're very grateful for those partnerships. We also, I would kind of characterize it as our bread and butter is our support groups. When I joined the CSA 3 or 4 years ago, we had 2, Hamilton and Ontario. We now have over 13. We've piloted over the summer a few different virtual sessions, and we had the opportunity to do that successfully. Many of our in-person support groups are pivoting to be virtual or online, and those are going quite successful as well. So if you're interested in you know, getting and participating in those sorts of programs, please reach out to either myself or Wendy to help connect you to hopefully a support group in your individual region. And we'll look to continue to I guess, expand that offering. Also want to point you to 2 additional upcoming events that we'll have. In 2 weeks, we have a webinar on managing pain and inflammatory arthritis with Dr. Max Sun. And several weeks after that, we have a webinar with Dr. Jonathan Chan, the treatment journey starting at diagnosis, both of which are continuing to support the resources that we have for those living with spinal arthritis. To register, there's a link there. It's on our website under the latest events. And we also have the series of different webinars, including the series of in-person information sessions on the website if you're interested in any of those. Just as an important caveat, we're providing information, not medical advice, and we recommend that all of you discuss the information shared by Dr. Chandran or also the other resources on our website with your team of medical professionals. This is, I think, paramount to ensuring that you get the care and support needed to live well with these chronic illnesses. With that, I might stop and invite Dr. Chandran to take over. I'm going to stop the screen and want to appreciate all of you joining us and look forward to the presentation.
Can you all see the screen and hear me well? Okay, great. So thank you, Graham, for that introduction, and thank you all for joining on this important day, October 19th. Many of you, or some of you at least, might know that I'm in Toronto at the University Health Network. When I was scrolling through the chat box, I recognized a few names, so thank you for showing up and supporting me. It's always difficult to speak to a computer screen. The only person I can see is Graham, and I'm hoping to see all your faces there and recognizing some of the names. I can imagine you're there looking at me and cheering me on. So what I'm going to talk about is psoriatic arthritis, and these are my disclosures. I've worked with industry, with some book companies, publishing books, etc. And so there is some financial conflicts of interest here. I have salary support from the Pfizer Chair in Rheumatology Research Award from the university, not directly from Pfizer, but through the university. And my spouse works for Eli Lilly, which is again a big conflict of interest. So over the next hopefully 20 minutes or so, what I'm going to talk about is about what psoriatic arthritis is and how it's related to spondyloarthritis. We'll talk about some clinical features of this disease, how it's diagnosed, how do you manage it, and what the unmet needs are. And it's meant to be brief, and we can have discussions after. Hopefully, I'll not be too long so that we can have a good discussion, Q&A. So what is psoriatic arthritis? It's a spondyloarthritis, and I'll come to describing that better, which is a form of inflammatory arthritis. And it's defined as it is such a condition that is associated with psoriasis, which is a relatively common skin condition, inflammatory skin condition that affects about 3% of Canadians. So what's a spondyloarthritis? The term spondyloarthritis indicates that the spine, the sacroiliac joint and the spine is an important joint that is affected by this condition. Now, not all patients with spondyloarthritis have spondylitis. You can have spondyloarthritis with no involvement of the spine and only involvement of the peripheral joints. And when we say peripheral joints, that are joints that are outside the spine and the central axial skeleton. So you're talking about joints like the joints in the knees or hands. And so arthritis, that is inflammation of these structures, is an important feature of spondyloarthritis, just in addition to the spinal involvement. So you can have in the lower limbs, which is very typical of spondyloarthritis, and sometimes it's only present, say, for example, in the feet, and therefore a diagnosis is sometimes missed. You can also have involvement of the hand, especially in psoriatic arthritis. The other important feature is what is marked by these red spots, say behind the heel, on the elbow, and on the spine. This is what is termed enthesitis, that is inflammation with the tendons or ligaments attached to the spine. So this can be at the back of the heel. There are many entheses, but the common sites would be the heel, the side of the elbow, and it's very similar to so-called tennis elbow. And then also on the bony prominences in the back of the spine, the spinous processes. And most important, one of the important sites is the spine, just behind the neck, the C7 spine. Another important feature is what we call dactylitis, when there is swelling of the entire digit. Here, I'm trying to show the fourth finger here being inflamed by this dactylitis, and I'll come to that soon. And there's always this confusion about, is it psoriatic arthritis or is it axial arthritis with psoriasis, and how these terms are related. So this particular diagram that I'm going to shows you the relationship between all these spondyloarthritis. So you can broadly classify all patients with psoriatic arthritis, not all patients with patients with spondyloarthritis can be broadly classified as having predominantly axial involvement. So these patients come with back pain being the most important symptom or the early symptom or the most severe symptom. Their hands and feet, etc., not being that much of a problem. And then there are patients who have predominantly peripheral involvement. They may or may not have any back end involvement, or the back involvement is quite minor and not bothersome. That's what we call predominantly peripheral spondyloarthritis. So these are two broad class categories, and of course there's a significant overlap. And so patients can have axial and peripheral. So some people have both bad hands and feet involvement and back pain. And then within the category of predominantly axial involvement, if the X-rays of the pelvis show what we say satisfy New York criteria, which is a technical term and sometimes difficult to figure out, but if that is true, then that patient is said to have ankylosing spondylitis. And suppose you're predominantly axial, but the X-rays are normal or non-diagnostic, then we call that people with that condition non-radiographic. So non meaning not present on radiograph, meaning X-rays. So most of the time have changes on MRI. X-rays are normal, but MRI is positive. So that's what is predominantly axial. Now, patients with predominantly peripheral arthritis, if they have psoriasis, that's psoriatic arthritis. Now, patients with psoriatic arthritis may also have axial involvement. So it does not mean that they only have peripheral, but you can see that when you have a spondyloarthritis and psoriasis, that's when you call it psoriatic arthritis. And most patients have peripheral involvement. A few have only axial involvement. And then if you have inflammatory bowel disease, then it's called arthritis-associated inflammatory bowel disease, arthritis with IBD. If the spondyloarthritis is triggered by an infection, usually a genitourinary or a gastrointestinal one, then that's called reactive arthritis. And then if you have predominantly peripheral spondyloarthritis, but you don't really fit into any of these criteria, then you're called undifferentiated. So these are the various terms that you might have heard as you read the literature or some of your doctors saying that. As you can see, there's a lot of overlap. So a patient with psoriatic arthritis may also have ankylosing spondylitis, and that's why it leads to a lot of confusion. But this picture kind of tries to give an explanation of these different terms. Now, spondyloarthritis is a condition that I just described. Now, there are a few autoimmune diseases that are closely associated with that. So either the patients have this along with the arthritis or spondylitis, or they have close family members that are have this condition. And the important ones involve the skin, the GI system, and the eye. So skin, typically psoriasis. GI system, it's inflammatory bowel disease, not irritable bowel disease, but inflammatory bowel disease. So IBD, not IBS. Crohn's disease is the most important association. Ulcerative colitis, less so. And then you can also have inflammation inside the eye, uveitis, these are commonly present and tend to be present as with the longer that you have the disease, and it's something that we need to look out for, and also helps make the diagnosis. Suppose you have uveitis and have back pain, then it's likely that you have ankylosing spondylitis. Same thing, we have psoriasis and we have joint pain, then you're always looking out for psoriatic arthritis. Some clinical features: you can have quite bad psoriasis as shown here, or it could be hidden. It could be, between your butt cheeks, so between the nasal cleft, or maybe in your umbilical, your navel, your belly button, or in your scalp that you've not noticed it. And so when as physicians we see a pattern of arthritis that may suggest psoriatic or other spondyloarthritis, we're carefully looking for this on the skin, even if the patient is not aware, right? Sometimes it's hard to see your back, for example. The nail disease is integral to psoriatic arthritis. If you have psoriasis and nail disease, your likelihood of getting psoriatic arthritis is quite high. And so we always look for the nail disease. And by itself, nail disease is a problem, just like the skin disease. Then you can have what I just mentioned earlier, peripheral arthritis. You can have inflammation of joints in your hands and feet, knees, shoulders, elbows, etc. And typically that causes swelling and redness in these joints. Can also affect the joint next to the fingernail, the DIP joints, which is quite typical of psoriatic, usually not seen in other forms of inflammatory arthritis, but can be sometimes be confused with osteoarthritis. And this can be progressive and causing deformities like this, and sometimes quite destructive, like the bottom right figure here. But thankfully, you don't see such bad arthritis anymore. We tend to see more early disease because of more awareness and early diagnosis. Spinal involvement is common. About a third of patients with psoriatic arthritis, when they come to a clinic, if you look for it, you'll find spinal involvement. And if you look at 100 patients, over the life course, about 50% of them would get some sort of spinal involvement. So that's an important thing to look for. And if spinal involvement is present, we have shown that you tend to have much worse peripheral joint involvement also. So that's a marker of severity. The other important diagnostic kind of feature is dactylitis, also known as sausage finger or toe, sausage digit. What it means is that the whole finger or toe is swollen. So if you look at this finger here, you can see it's uniformly swollen. You can see this middle finger here, uniformly swollen, this index finger, and the fourth toe. For some reason, the fourth toe is a common site. So when you have these sausage digits, there are very few conditions that can cause it. So spondyloarthritis becomes top of the line. And many times you see patients who just have a swollen sausage digit and nothing else, and then when you evaluate, you see that there is psoriasis hidden somewhere, or there's a family member with psoriasis, then you can make the diagnosis. Other feature is enthesitis, and the common site is the heel. So enthesitis is where the tendons and ligaments attached to bone, the inflammation there. So this is the Achilles tendon, one of the biggest tendon in our body that is inserted into the back of the heel, and that insertion sites can get inflamed. That's Achilles enthesitis. Not tendinitis, where you find the inflammation up here in the tendon area, but no, this inflammation is where it inserts into the bone. The other common site is where the plantar fascia inserts into the bottom of the heel bone, and that's again a feature of spondyloarthritis, plantar fasciitis. I mentioned uveitis, inflammation in the uvea. So we always ask for these symptoms and look for it if there is any symptom, any problem, and then always ask for bowel symptoms and Crohn's disease. So on follow-up and initially, these are things that we look out for. Now, what I mentioned until now, what happens in the joints and what happens, so those arthritis, ankylosing spondylitis, reactive arthritis, IBD-associated arthritis, you can characterize them as being, brothers and sisters. And then we talked about psoriasis, IBD, uveitis, which are more like cousins. So they are part of the family. And then there are conditions called comorbidities, which are much more prevalent in people with these conditions, and which has a huge influence on the long-term outcomes. So these comorbidities, and important ones, especially with psoriatic arthritis, is obesity and metabolic syndrome. So for a variety of reasons, obese people with metabolic syndrome who are likely to get diabetes, but also are likely to get psoriasis. And also obese psoriasis patients are also more likely to get psoriatic arthritis. So it's a close relationship which we are trying to disentangle. Inflammation is bad. In addition to the risk factors to cardiovascular disease, so people with, everybody has some amount of cardiovascular inflammation as one gets older, but when you have an inflammatory disease, it tends to happen sooner. And so there is a higher prevalence of cardiovascular disease, heart attacks, and strokes, especially in people with psoriatic arthritis and psoriasis, just as in other inflammatory diseases, including ankylosing spondylitis. And what drives it is not just diabetes and say high cholesterol, but also the inflammation. So in heart disease manifestation is caused by low-grade inflammation, and if you have another inflammatory condition, you tend to have more of this inflammation in your blood vessels, ultimately leading to heart disease. And then the big thing, which is very much less studied, is the high prevalence of anxiety and depression. There are many reasons for it. The stigma of the skin disease, pain, severe fatigue, and poor sleep. And all that causes poor mental health. And people with anxiety and depression tend to do poorly, respond less well to treatment, and have poorer long-term outcomes. And mental health is not just what are the factors that I mentioned, but inflammation also is an important driver for mental health issues. So how is this psoriatic arthritis diagnosed? The big problem is at the bottom. There is no diagnostic test. So somebody who's suspected to have psoriatic arthritis need to be carefully evaluated by a person who knows about inflammatory arthritis. So typically a rheumatologist. And since there are no tests, what a rheumatologist is trying to do by taking history and examining you and looking at x-rays and imaging is to look for this characteristic pattern of inflammatory arthritis. Now, the biggest challenge is that the things that I described, pain and swelling in, say, the joints of the hands, the heel pain, back pain, that happens in normal folks, in the sense people who do not have psoriatic arthritis or spondyloarthritis. There's nobody that I know of does not have back pain. When you get older, you tend to get all these issues, and osteoarthritis affects the same joint that psoriatic arthritis affects. The pain and inflammation at where the tendons attach to bone, like the plantar fasciitis, the tennis elbow, that happens, without inflammation too. And if you look at carefully, there is some low-grade inflammation in these situations, but not as much as in psoriatic. So how do you decide that a tennis elbow is just a tennis elbow and not enthesitis and psoriatic arthritis? There's no definitive test. You'll have to, the judgment, so the history and the examination, imaging like an ultrasound and MRI, all that has to be taken into consideration, and then the expert has to decide, yes, this is really inflammatory and therefore spondyloarthritis, and if there is psoriasis, psoriatic arthritis, right? It's not easy, and that's where commonly, not uncommonly, you will see, you go to one specialist to get a diagnosis, you go to another one, they say, oh, you didn't have it, and then there's all this confusion that goes around, and that's because there's nothing that by itself will give you a diagnosis of psoriatic arthritis. You have to take all that into in a proper perspective. So once the diagnosis is done, how do you do? What do? You have to manage the condition. So what's important in management? First thing is education of the disease, and one of the webinar today is to further that agenda. And the CSA, thank you for taking this forward. Then it's about general health measures. If you smoke, stop smoking. Regular exercise is good, brings down inflammation, improves your mental health, manages your weight. I mentioned obesity being a big problem, and so losing weight, if obese, would be a good idea. When you lose weight, you'd respond better to whatever treatment you're on. The skin gets better if you have bad psoriasis. So all that is good. Stress management is important. More stress, more pain, more severe psoriasis, more inflammation in your joints. A good sleep plan, it's easy for me to say, but when you have pain and fatigue, it becomes difficult, but trying to get into a good sleep rhythm is important. And then, of course, medications are important in managing these symptoms. Not everybody requires biologics, and there are people with psoriatic arthritis who don't need any treatment, and they do really well with regular exercises and weight management. Then there are what we call anti-inflammatory drugs. These are mainly for reducing pain. The drugs like naproxen, ibuprofen, celecoxib, some of them are available over the counter, and the lower doses and higher doses are prescription-based. They do good relief, especially of enthesial pain, back pain, and some of the joint pains. Steroids, we don't really like giving oral or intramuscular steroids. They're not very effective and has a lot more side effects. Makes obesity, diabetes worse, and sudden stopping steroids can make your psoriasis worse, so we generally try to avoid it. but it's preferably if one or two joints are inflamed, then you can inject those joints, and that gives good relief. So preferably intra-articular steroids. And then the traditional conventional immunomodulatory drugs like methotrexate, either as tablets or injections, sulfasalazine, 2 milligrams per day, and leflunomide. All these drugs are useful for psoriatic arthritis involving the peripheral joints. Not so much if it is primarily the spine. So these conventional drugs are not helpful for back involvement, although the anti-inflammatories are quite good for back pain. And then there are the newer drugs. For the almost 20 years now, we have the anti-TNF agents, beginning with etanercept, and then infliximab, adalimumab, golimumab, and certolizumab. There are 5 of them, and now we have the biosimilars of at least 3 of them, and so a lot more options for managing very severe psoriasis and psoriatic arthritis with anti-TNF agents. These are generally quite safe, but there are some particular side effects that one has to watch out for, and an expert rheumatologist would have no problem in managing that. Then there are other non-TNF anti-TNF biologics. Some of them T-cell directed drugs like abatacept, which is sometimes not very common, occasionally used for the management of psoriatic arthritis, not so great for psoriasis. And then more recently, drugs targeting the so-called Th17 pathway, and we have 4 of them listed here: ustekinumab, secukinumab, ixekizumab, and guselkumab. So quite effective for spondyloarthritis and psoriasis. But there are some nuances. There are differences between these drugs. For example, if you have significant back involvement, you would not go with ustekinumab. If you have a high risk for Crohn's disease, you would not go with secukinumab or ixekizumab. And guselkumab, again, if significant back disease, you may not go with that drug. There are tablets, which are also advanced therapies that are available. Apremilast is an oral pill, and another one is tofacitinib, again, an oral drug. And these are for the joints. Tofacitinib is as effective as the anti-TNF agents. Apremilast less so, but it's very little infection-related side effects, and so quite safe. You don't need any monitoring. So those are why these drugs are quite useful. And what else do you need to do? You need to monitor once you have the disease and you're on treatment. Always monitor for these cardiovascular risk factors, diabetes, hypertension, weight management, lipid profile. Stopping smoking is important. When you're on some drugs, you need specific monitoring for that. Before going on, say, methotrexate, you would look at hepatitis viruses to see that you don't have it, and then you monitor white cell blood counts, liver functions, and kidney functions. With anti-TNF and other biologics, you have to screen for any latent infections, tuberculosis, hepatitis viruses especially. And this is recommended depending on where you practice and where, you have an assessment of what the risks are. And then blood monitoring, not really that important, but some people do it every 3 months. If there are any infections, they treat with antibiotics early if you have bacterial infections. And vaccinations, live vaccines are generally avoided. So to get all your vaccinations before you go on to these more stronger, if I may call it, immunomodulatory therapy. Unmet needs, quite a few. One of the unmet needs is pre-diagnosis. Could you diagnose or identify patients with psoriasis who are at high risk of developing psoriatic arthritis? And if you could do that reliably, then can you intervene to prevent psoriatic arthritis from happening? So like the holy grail. The other one would be early diagnosis. You have some joint complaints. Can that be diagnosed early? Another unmet need is how active is your disease, because you look at so many things, your skin, your joints, your enthesis, your back. It's very hard to come up with a definitive criteria that you're actually active, because the blood is usually normal. And so if you have better markers in the blood or otherwise to ensure disease active, to identify disease active, that'd be good. And then can you prognosticate when somebody gets a diagnosis? Are you going to do well? Are you going to have severe disease? Are you going to get joint damage? Mental issues, cardiovascular issues, and the right drugs for you at the right time. All those are unmet needs because at the moment it's all trial and error. Hopefully in the future we'll have a better system of identifying the right drug and the right approach to each patient. This particular slide just shows the typical course of psoriatic arthritis, where you almost 85–90% get the skin disease first, psoriasis, and then something happens in your immune system and you have the so-called preclinical PSA where the immune system is acting up, but you're otherwise feeling fine, and then you start getting some inflammation in your joints. Then there is more and more pain, and finally a diagnosis is made. So the idea is that if you can identify patients with psoriasis who don't have arthritis but are likely to get it, you could do something to prevent that from happening. We know that about 2.7, so about 3 people, if you follow 100 patients with psoriasis for a year, 2 or 3 of them would get psoriatic arthritis. And that, it does not depend on how long you have psoriasis, it can happen anytime. And the risk factors are bad skin disease, nail disease, presence of uveitis. And so these are people, when you have these conditions, you're going to follow them up more closely to identify psoriatic arthritis quickly. Other risk factors, family members. So if you have a person with psoriatic arthritis, his family members have a risk of about 30 times the general population of getting psoriatic arthritis. This was a study that I did many years ago, roaming around in Ontario, visiting people's houses and examining family members. And the prevalence was quite high compared to the general population, and putting the relative risk quite high. The lambda is a relative risk, about 30 times the general population. So if somebody with psoriatic arthritis, close first-degree relatives, parents, siblings, children complain of joint pain, then it's good to have a good evaluation to rule out psoriatic arthritis. So to improve outcomes long-term, what patients in CSA can do, awareness, like just we're doing today. General public, patients with psoriasis, family physicians, dermatologists, all of them need more awareness. I think the awareness among dermatologists now is pretty good. Family physicians, I'm not so sure. Important thing to let people know is that there's no blood test. Your blood, inflammation markers in your blood could be quite normal. And so a blood test is not going to identify the disease. And you proactively ask psoriasis patients, their family members, if they have so-called inflammatory kind of joint pain, and which is not that easy to define. So I would say if you have significant joint pain, best to consult a family doctor, get a referral if need be for a proper evaluation. For early diagnosis, what do? We ask psoriasis patients, look for these risk factors that I mentioned, nail disease, bad psoriasis, all those are important risk factors. So they should be carefully evaluated, and family members, like I mentioned earlier. And when you see your GP or a dermatologist, you might wonder, oh, it's a skin doctor, I don't have to talk on my joints. But when you have psoriasis, if you have joint pains or heel pain, so-called enthesial pain, then mention that. Doc, I have that. Maybe I need an evaluation. Maybe I'm getting psoriatic arthritis. So putting it out there would force or also educate the clinicians to look at it more carefully and do the appropriate referrals. And when you see a rheumatologist, what should you do? You should talk about joint pain, talk about sausage digits if you have had it, talk about back and neck pain, sometimes it's not asked, heel and elbow pain indicating enthesial pain. A complete and careful physical examination is important. So even if you're not asked to disrobe and remove your footwear, I would say do that and say, please look at my feet, it hurts. Maybe there's something going on there. Look at my spine, look at my skin carefully. Is there hidden psoriasis in the umbilical cord or in between the between the buttocks? Look at my nails carefully. And then if there are things going on, then that indicates a diagnosis, then you might need further investigations, blood tests and imaging, x-rays, MRIs, whatnot. And go with all the comorbidities that you have, when it was diagnosed and what treatment you're on, what associated disease you've had, so that they get a quick picture, and then all medications. When did you start it? When did you stop it? What was the response? So with that, I think I'm running out of time here. So what I've tried to do over the last, I think, 20-25 minutes was to talk about what psoriatic arthritis and how it's related to spondyloarthritis, what its clinical features are, how it's diagnosed, and how do you manage it, and what the unmet needs are, and what as patients and family members and advocacy organizations can do to get the awareness out there and get practical management of diagnosis and management of patients with psoriatic arthritis. And to summarize, I've said that psoriatic arthritis is one of the spondyloarthritis. It may affect the joints, spine, or other organ systems. It is associated with other conditions, so-called comorbidities, obesity, diabetes, depression, anxiety, will lead to more cardiovascular disease. It requires diagnosis requires a careful evaluation by a rheumatologist. There are no diagnostic tests, and it's important because early diagnosis leads to better outcomes. And if there is persistent inflammation, that leads to poor short and long-term outcomes. And now effective therapies are available, if the inflammation is persistent despite usual measures, then being on immunomodulatory therapy does prevent further joint damage progression and reduce the risk of cardiovascular disease, and also improves mental health. So with that, I'll stop there. This is our team in Toronto. We have a big research program, which includes not just rheumatologists, me and Dr. Gladman sitting in the center, but also dermatologists, Dr. Rosen. We have statisticians from England and from Waterloo. We have patients here. Some of them that you can see here are patients in a clinic who are part of our advisory group, a lot of trainees, and we try to reflect the great diversity that is seen in Canada. And with that, I'll stop, and I'm happy to take any questions.
Hi, Dr. Chandran. This is Dan. Wendy's having a little bit of difficulty connecting, so I'm going to be asking the Q&A for you here.
Sure.
We have a question. First question, looking forward, are there any research studies being done to come up with a diagnostic test to definitively get a diagnosis?
Yeah, so diagnostic tests has been a big unmet need. So just like CSA, there's a big organization in the States for patients with psoriasis and psoriatic arthritis called the National Psoriasis Foundation. Many of you must have heard about it. They put out a call for applications a couple of years ago, asking research team to apply for this competitive grant to develop a diagnostic test. So in the initial round, they've selected 6 groups across the world to develop it, and we are one of them. And we have been doing particularly looking at molecular markers, meaning DNA, proteins, metabolites that we can easily look at from the blood, and to see what are the markers that best identify psoriatic arthritis in patients with psoriasis. And we have to the next phase of the funding would, we've got to reapply in the middle of next year. And if we are successful, we get more money from the NPF, the National Psoriasis Foundation, to work more on the diagnostic test. And so my rosy expectation is that in about 5 years, we might be there. But yes, there are multiple research groups working on developing the diagnostic test.
Great, thank you. The next question we have, someone asks, I have experienced and learned through webinars that the time from beginning symptoms to diagnosis can take up to 10 years. Is there any current research being done to shorten that time frame? Well, I guess that would be the same answer. I'm going to leave that to you, but I believe that would be the answer there. Is that correct?
Right, yeah. So spondyloarthritis, across the board, there's a delay in diagnosis, be it ankylosing spondylitis or psoriatic arthritis. And we've shown both here and other studies in Europe that the more delay there is, the worse is the outcome. And so, diagnostic tests would help in early diagnosis, but also the awareness, especially dermatologists and primary care about the presence of psoriatic arthritis in people with psoriasis. And I think more importantly, patients with psoriasis, we can reach out to them and say, if you have any joint pains, do ask your doctor to look for psoriatic arthritis, because I think, an empowered patient is more likely to get the diagnosis quicker rather than, leaving it to the physicians in general. So more awareness, diagnostic tests, all that would help. And there are, like I said, a lot of research going on in North America as well as Europe.
Great. Thanks for that. And the next question we have, what is the role of the microbiome in the development of PSA?
Right. So the microbiome in PSA is interesting. The microbiome is, for people who don't, it's the bacteria or any other organisms that live within our body. So usually what is looked for is in the gut. So usually by looking at the stool samples, you can also look at the skin, you can look at the mouth from oral microbiome. So most of the studies have been done with the stool microbiome, and there are differences between psoriasis and psoriatic arthritis. So generally speaking, when you have an inflammatory disease, you have less diverse biota in your body. So, and when you look at the microbiome of the patients with spondyloarthritis, including psoriatic arthritis, they resemble more the microbiome that is seen in people with Crohn's disease. So the number of studies that have looked at psoriatic arthritis microbiome is small, but they seem to show that it's similar to Crohn's disease. The other complicating factor is that, as I mentioned earlier, there is obesity. So the obesity is again, and metabolic syndrome is also associated with gut dysbiosis. And so both these factors are operating in psoriatic arthritis. And so one of the studies that we are doing, we looked at the skin microbiome, and then we have a project on the gut microbiome and to figure out how different it is. And the question, of course, is that if you can then intervene by changing the microbiome, but there are many ways of doing it, can you then improve the arthritis? And you might know that there are studies where you give fecal bacteria in pellets that you can take in, or you can in bad gutly inflamed conditions like Clostridial difficile infections, you can introduce microbiota into the gut to reduce inflammation. But the other methods of changing the microbiome is by exercise changes the microbiome to a better one. Good diet with a variety of vegetable, high fiber foods also increases the diversity of microbiome. So all these are good things, and some people believe, a lot of people believe that the bad consequence of obesity and the improvement that you see when you lose weight, etc., is mainly going through the microbiome. And so getting a good and diverse microbiome is going to improve a lot of outcomes, including psoriasis and psoriatic arthritis.
Great, thank you for that. Now, outside of microbiome and obesity, are there other dietary changes that could impact disease course? So losing weight by whatever means has been shown to improve both psoriasis and psoriatic arthritis. So there were studies that looked at different kinds of diets, but end of the day, what mattered was whether you lost weight or not. So at the moment, we have a study that is ongoing where we're looking at Mediterranean diet, which is considered one of the best diets for reducing inflammation, versus just a caloric restricted diet to see what the differences are. And we'll be looking at, in a trial, what happens when the diet is given to people with active psoriatic arthritis and what the changes in the microbiome and the metabolites in the stool are. Bottom line is, if you lose weight, then it's good. And maybe if you have a very good diverse microbiome by an appropriate diet, and I don't know how to do that. We're still hard to give recommendations because those studies have not been done, but these are good immunomodulatory treatments for this condition. And hopefully we'll have a better answer once these studies that we're doing are completed. Great, thank you for that. The next question we have, someone's thanking us for this wonderful presentation and also says, is the relationship between stress and inflammation physiological or more related to mental health? I hear conflicting reports of whether stress can actually make symptoms and inflammation worse.
So in psoriasis, the relationship has been much better described. If you're under stress from whatever, from any condition, the most, dramatic example was given to me by one of the physicians in California. There was a worker who had very mild psoriasis who was working on one of the, cable, or what do you call it, tower, one of the towers in 88 or 89. And that's when the major earthquake happened. And so he was working on top of the pole, a big tower, doing his work. And because of the earthquake, he swung back and forth during the tremor and got a scare of his life. And then the next day, within a few hours, he started noticing changes in his skin. And within a few days, he was covered with psoriasis, which is a dramatic example of what severe stress can do. And but it's hard to study stress, right? There are studies out of Manchester where they exposed patients to stressful situations and then did skin biopsies to show how they could demonstrate changes in the immune cells before and after that stressful event. So I think there is this psychoneuroimmunology is a scientific study of these effect of the psychic factors on the immunological function. So I think there is a direct relationship, although it's quite difficult to study.
Great, thank you for sharing that. Next question we have, could bunions be an indicator?
So when you say bunions, is it that it's at the big toe, the bone protrudes out and it's Hallux Valgus in medical terms? That's quite common and not necessarily psoriatic arthritis. It's more osteoarthritis because in psoriatic you'll have there is of course some new bone, extra bone that forms, but most of the time there is destruction. So if it is clearly bunion, then it would be less likely to be psoriatic arthritis, more likely to be osteoarthritis.
Great, thank you for that. Arthritis without having the skin psoriasis.
Yeah, so I mentioned psoriasis as being an important diagnostic feature, but not everybody has it. I mentioned that most 85 to 90%, say I would say 85, first get the skin involvement, 85, 90%, and then the joints. And so then it becomes a little more clearer. But there are these 10, 15% we get the joint disease first with no skin disease. And that's the so-called psoriatic arthritis without psoriasis, PSA, sine psoriasis. Now, the psoriasis can come later and then it becomes clearer, and that happens quite often. But sometimes you may never get the psoriasis at all. Most of the time, a close family member might have psoriasis, which gives you a clue. But what the rheumatologist is looking for is not, skin disease gives you a clue, but it's usually the pattern of arthritis. Which joints are affected? Where is the inflammation? Is it more inside the joint, or it's in the enthesis when you do, say, an MRI? All that gives an indication. But yes, there are patients with psoriatic arthritis who never have any psoriasis.
Okay, great. Next question we have here, which could be on a lot of people's minds during the current climate. Do you foresee any problems with mRNA vaccines?
You got cut off there, but you mean any problems with the mRNA vaccines for COVID-19?
That is correct.
Yeah, good question. Yeah, so we don't know much about these vaccines, and people with any immunomoderate conditions I don't think are being tested in the early phases. But given the mechanisms, I wouldn't think mRNA vaccines will be a problem. I believe. I don't know much about these vaccines. I apologize. I need to read more about it. Typically speaking, if you're not on any immunomodulatory therapy, then there's no problem in getting vaccines. If you're on a immunomodulatory drug, then current recommendations are to avoid live vaccines. So the mRNA vaccines wouldn't technically be the so-called live vaccines, like, for example, measles vaccine. And there are studies to see if that is actually a problem, giving live vaccines to people on the drugs that we use for controlling inflammation, and did not seem to be a problem, but it's still best, recommendations are still best to avoid it. The other problem, of course, is that if you're on an immunomodulatory drug, you may not actually develop enough immune response to the vaccine because your immune system is a little suppressed, right? So, and so you may not have the same protection if you're on immunomodulatory drug compared to somebody who's not on it. So these are things that once a vaccine is available, we'll have to figure out. But I would still say getting the vaccine, for example, a flu shot, is even if you may not have enough protection, at least there is some protection. And so that's always a good idea to get all vaccinations done, which are recommended.
Great. Thank you for that. We are now approaching 8:30, so we will get one more question, and then the rest of them, what we'll do is we'll get them to you and see if we could publish them later.
Sure.
Now, for the last question here, am I correct that peripheral spondyloarthropathy, a newer classification because it's hard to find good information of my diagnosis? Any recommendation on a website?
Right. The axial and peripheral spondyloarthritis, the so-called ASAS criteria, that is not meant for diagnosis. Those criteria are meant for the physician once they're made once you have a diagnosed patient to see if the person is eligible for a clinical trial, for example, or a research study. These are not diagnostic criteria. These are classification criteria. So there's a difference. So I would generally say that for a diagnosis, those criteria are not important. There are many things, other things that go into a diagnosis rather than these criteria. Having said that, the ASAS, there is an organization, I think CSA is a member of, I think it's the ASIF, that has a good booklet that talks about, spondyloarthritis in general, a little more focus on the axial disease. But now with there's a lot more interest in peripheral arthritis, and so there is more awareness of that going on, and so they've talked about it. But I would stay away from the criteria because it's mainly for research studies to include people in all these studies and trials. But for the diagnosis, I would say reading about it is the things that I talked about. You can have joint involvement, usually the lower limbs, but also in the upper limbs. You can have the so-called enthesitis, inflammation of tendons and ligaments attaching to bone, and dactylitis, with the other features which may or may not be present. But the peripheral features would be arthritis, enthesitis, and dactylitis. And looking at the ASIF, or there's something called the PSA Facts. That's a small book that we have written with Oxford University Press some time ago. Those are the books that would talk more about psoriatic arthritis. I'm not aware of any such resource for peripheral spondyloarthritis. Unfortunately, that's been not that well researched in most parts of the world.
Great, thank you. Can you hear me now?
Yes.
We can hear you.
Oh, good. Sorry about the technical difficulties I've had. I want to thank you, Dr. Chandran, for speaking with everybody tonight. There's several questions, as Dan mentioned, that have not been answered, so we'll try and kind of theme those and maybe see if you can spend a few minutes and quickly do a quick response that we can share back through email. So again, thank you for taking time out of your schedule. We know how busy you normally are, and during the COVID pandemic, probably even more so trying to juggle seeing patients virtually and in person. So we really appreciate you taking the time to join us tonight. I also want to thank everybody who's on the line with us and who registered. We had well over close to 250 people registered this evening. So For those who haven't been able to make it, we will be posting this on our website and making it available for people to view at their leisure. And for those that are on the line, if there's anything that you want to go back and take a look at, you're welcome to do that. Just a reminder, we have another couple events for to close out 2020. We have a webinar on pain and a webinar on the holistic treatment journey of from diagnosis onward. So hopefully that's of interest to many of you, and that you'll register to join us on those events. You will be receiving a short evaluation after the webinar this evening. I hope that you will take 2 minutes of your time to complete that. Really important and helpful to us when we're trying to bring programs and resources that are of help to you and of value to you in your journey. Again, with that, I'm going to close the webinar, and thank you again for joining us, Dr. Chandran and everybody on the line. Take good care, and everybody keep safe, keep healthy during this the COVID-19 pandemic, and we hope to see you at our next webinar. Thank you. Enjoy your evening.
Thank you. Good night, everyone.